All right, guys, I guess we'll get started since we're live streaming. So, welcome to a special edition of From the Clinic to the Living Room. Today, I actually am going to be talking about genetics and melanoma. We're going to try to understand genetic testing, how it plays a role in the melanoma diagnosis, prognosis, and therapy. I'm Melissa Wilson. I'm a physician assistant at Hillman Cancer Center. But I also am Ames Ask an Expert. Today, we're going to be joined by someone who I absolutely adore. Um, Her name is Dr. Yana Najjar. She's Associate Professor of Medicine at UPMC and also the Director of Clinical and Translational Research Center at UPMC as well. And she's a fabulous melanoma specialist, and I'm so happy to have her back on my webinar.
It's
Yana, thanks
incredibly
for
kind. Thank you for having me back. Hi,
my
Melissa. Hi, everybody.
You're wonderful. So today, the whole topic of genetics in general can be extremely daunting because
Mhm.
we use it in different aspects of melanoma. So I'm hoping that today we can kind of break it down. You're amazingly wonderful at doing this with your patients. And so, just kind of break it down into different segments and sort of get a basic understanding of how we sort of use genetics in melanoma. So I know that we use this for risk, we use it for the need for sentinel node, we use genetics for mutational testing, we use it for prognosis. So this is, a vast topic. We probably could spend an entire hour talking about each aspect.
Absolutely.
But so why don't you kind of start us off with telling us generally, what is the role of genetics in melanoma as you see it?
I think it's important to set the stage and to explain. I'll do certainly my best to explain this in layman's terms, but as I tell my patients, if I devolve into gibberish, please tell me. When we talk about genetics, most people will think that we are referring to looking for an inherited syndrome in the family. Every patient with cancer of course, wants to know why this happened. And so oftentimes I think about, is this something that I inherited from my mother or my father? That's the typical take, if you will. Oftentimes in melanoma in particular, when we talk about genetics, we are not talking about that, although certainly
Right,
there's a place for that. We are talking about the genetics of the tumor itself,
right,
which are distinct and completely apart from the rest of the patient. So in clinical terms, we call those somatic mutations. Somatic mutations are those that are present in the tumor and are particular to the tumor. Whereas germline mutations, which is what people think of when we talk about genetics, from mom, from dad, germline mutations are present in every other cell versus somatic. So I just wanted to make that distinction, which is very important. And unless we specify otherwise, I think we will be more focused today
yes,
on somatic mutations, those that are particular to the patient's tumor. And if I were to look at a cell from the patient's leg or cheek, I wouldn't find that mutation. But if I look in a tumor cell, I find it there. And there's a very big role there because the mutations that we find in the tumor can help direct our thinking. For every one of my patients, when I think about therapeutic options, I am very well aware of whether they do or do not have mutations X, Y, and Z.
exactly. And you're absolutely right. That is really the meat and potatoes of what we in a clinical practice setting use genetics for every single day. So that is absolutely where we're going with our discussions today. I guess, one of the best segues into this is, are there, the AIM website basically talks about different types of genetic tests. We can link, the website that talks about the different, because there's hundreds of tests that are out there, essentially. But I guess when it comes down to it, what are the most important genetic tests that we really need to focus on today?
So when we talk about genetic testing that helps us to determine treatment, I would say in melanoma, and I'm sure most would agree, the most important is the BRAF mutation. And BRAF mutations are present in about 40% of melanomas of the skin. They are less present in less common subtypes. So, for example, if we have a patient with acral melanoma, subungual melanoma, which are less common subtypes of skin, or cutaneous melanoma, we see those less commonly. We see them less commonly with mucosal melanoma. We essentially don't see them with ocular melanoma. So, but in cutaneous, which is the most common subtype, that is really the driver. And it's the most important one for us to know about because there are standard therapies, three combinations that are available commercially, meaning these are already approved by the FDA. We've already done the trials to prove their effectiveness for that. And there are other mutations which certainly drive our decision making. And without getting too technical, there are things like fusions, or there are abnormalities that we can find in the tumor, for example, c-KIT mutations, different fusions that can also inform our thinking and treatment, but they are much less common, and these are not things that you will see nearly as typically as BRAF mutations.
Okay. So, I mean, you mentioned the BRAF mutation with cutaneous, and obviously we need that for metastatic adjuvant therapy treatment decision-making process. But even like taking a step back, you know, even before we get to treatment options, we're looking at, you know, do we need to do a sentinel node? Do we need to consider this in a patient that might be borderline, like 0.7 millimeters, for example? Do we need to do a sentinel node on that patient? I know each doctor is so specific with, you know, do they use things like the Merlin test and, you know, Decision DX and things like that. But, you know, do you want to comment a little bit about the use of those types of things in prognostics in terms of, you know, risk of melanoma and sentinel node?
Yeah, and I think you raise an important point with the language here. So when we're talking about BRAF mutation, for example, we're talking about biomarkers or biological markers that predict response to therapy. So BRAF mutation is an ironclad predictive biomarker. A patient with a BRAF mutation will almost universally respond beautifully to BRAF targeted therapy for some period of time, but that's a whole other
Sure.
conversation.
Yeah, exactly.
What you're talking about, Melissa, of course, is prognostic biomarkers. Are there biological markers that can help us to finesse the prognosis of the patient's melanoma? And do we need to put them through a sentinel lymph node? My very short take is that none of those assays are ready for prime time. And there are many who
Mhm.
are free to disagree with me, and I'm sure they do, but I think the science would back up my sense that we are not yet there. And
Yeah.
these have not been prospectively validated to a level that I think is sufficient. To my mind, if you are on the fence, truly on the fence, perhaps one of these assays can give you a little bit more granularity about whether or not you want to get a sentinel lymph node, but I really hesitate to make that claim because in terms of prognostic biomarkers, the most robust data that we have comes from our own staging system, the HACC 8th edition. And there we go by Breslow, ulceration. And there are many prognostic biomarkers, as you well know, that have not made it into the staging system that are very helpful, lymphovascular invasion, mitotic index, et cetera, et cetera. I lean on all of that before I look at perhaps some of the genetic assays. But I know that these are sent very often and patients ask about them. So I think it's important to explain why perhaps they're not used as typically by a medical oncologist at this point. But this is a huge area of research, and I think much more is to come. And it would be great to be able to refine who does and who doesn't need further surgery. One other thing I wanted to say, if that's okay, your first question about which mutations do we look at, I wanted to say BRAF is one that we look at because there's treatments I can use.
Mhm.
NRAS, I didn't mention, is one that we look at. We see maybe 20-25% of the time in cutaneous melanoma. That can drive clinical trial decision making. That can drive what we call off-label drug use. Off-label meaning there is some evidence to suggest that drug X can be helpful for an NRAS mutation, but it's not a standard thing. And so we really look at the totality of the data from the genetic testing for the patient when thinking about how to treat them.
Yeah, for sure. And part of the reason that I brought up, you know, the Decision DX and all of those kinds of things is because, you know, we get a lot of, and a lot of our viewers don't have the luxury of being able to go to a major medical center with melanoma specialists like our institution is, you know. So I get a ton of questions on my Ask an Expert line of like, well, this, you know, this test said that I have like a 5% chance of having a sentinel node positive. And I try to just remind them like, you know, we have AJCC guidelines for a reason and that it's backed by, so many years of data and scientific reoccurrence data. And, we just had a patient a few days ago that had a 1B melanoma with brain mets and had a negative sentinel node. So you're like, you never know what's going to happen. So it's like those kinds of, you know, tests, while they're great, um, I think, like you said, are not quite ready for the mainstream, um, frontline decision making. But, again, everybody has their own kind of vibe. And so that's why I was kind of curious, if you would share with our, patients and our viewers kind of what your thoughts were about that. So,
It's a very rapidly evolving space, and we could
yeah,
sit here in a year and I could tell you, oh, it's the best thing since sliced bread, and they've prospectively validated it, and this is what I do. It's just not there yet. And
yeah,
certainly I think most melanoma medical oncologists would share my sentiment there.
yeah,
And I think we're doing patients a disservice when we decide should we or shouldn't we on the basis of that alone. I think that the staging is still king because that is backed by tens of thousands of patients,
yeah.
as you know.
Well, I mean, I think that is true of a lot of these genetic I mean, taking BRAF inhibitors aside because they have, a treatment option. But like when you're looking at like prognosis and you're looking at future prediction of reoccurrence and things like that, which we'll talk about those tests in a minute. But like some of those things, you're not going to use them just by themselves. You're going to use them in conjunction with other data points. And so I think that's, true of a lot of these genetic tests that are available for certain things with melanoma. So, uh,
Yeah. And to give an example, if I may, in case any of our viewers are wondering, what do you mean if you're on the fence? If I see a 75-year-old who has major comorbidities and I'm really not enthused about, sending them to the OR, shouldn't I get a lymph node? They're just on the brink. Let's say this patient has one of these prognostic tests that tells me it's low risk. In that case, I might use it as an additional data point to sway us not to go for it, saying, this suggests to me that you may be low risk. But all things being equal in a patient who is fit for a sentinel node, absolutely, I would go based on their pathology.
yeah. So we talked, obviously about the cutaneous markers. And I don't really want to spend a lot of time on this because this is obviously more of a cutaneous space, at least for discussion. But are there other genetic tests that are available for things like mucosal and ocular melanoma that would be important for those groups of people to have testing done?
That's a great question. So for mucosal, I think of it in the sense that I want testing, somatic testing, testing of the tumor itself to tell me if there are mutations there. For example, c-Kit comes to mind because, of course, then we talk about utilization of TKIs and other less common mutations can be seen there as well. For ocular melanoma, you very commonly will have mutations in GNAQ, for example, and that in the current era does not drive treatment decision making because it's almost universally seen. But what's very important in ocular melanoma is a kind of, maybe genetic test is the wrong word, but we look at HLA typing, as you
Yeah,
know.
right.
And I explain that to the patient as I'm looking at your immune blood type. For lack of a better way of putting it, I want to see what immunologic markers your cells are presenting and what immunology machinery your cells use to show your immune cells what is going on there. And so HLA typing is very important, of course, because our front line for our patients with metastatic ocular melanoma is determined by whether or not they're HLA A0201 positive. I would also say in the current era where so much is evolving, clinical trial enrollment is often predicated on HLA type, if it's a
Yeah.
specific cell therapy or bispecific. So we know that for most of our patients. And we also, depending on the clinical trial, look at expression of different tumor markers such as PRAME, as you know. So, but this is all in the trial landscape, and there's a lot of testing that we do for every patient. If you look at our clinic notes, you might see that I will say patient X has metastatic melanoma, BRAF wild type, NRAS wild type, HLA positive, PRAME negative. There's so
Mhm.
much data that is now filtered through that
Right,
is utilized to decide what to do next.
right.
And of course, our hope is we never have to do anything next, and the first thing you do is effective. But if that's not the case, which happens about 50% of the time, all of this comes into play.
Exactly. So whenever we're looking at treatment options and we're looking at deciding, what treatment is best for patients, I think there's this myth that we're like, oh, well, if you're BRAF positive, you should get a BRAF inhibitor right off the bat. And I know that, we know that that's not the case. And so I wanted to just kind of talk about like how do the tumor genetics sort of play into deciding a treatment course for a patient?
99% of the time, regardless of a patient's mutation status, we start with immunotherapy. And like everything else we do, that is driven by data that was very robustly generated. And of course, here I'm referring to the DREAM-seq study, which showed that for an all-comer population of patients with metastatic melanoma, each of whom has a BRAF mutation, the question we were trying to answer was, is it better to start with immunotherapy or with what we call targeted therapy, which is a combination of BRAF targeted therapy and then also MEK inhibitor therapy, which is really essential because otherwise the cancer cells outsmart the BRAF inhibitor very quickly. And the summary of all of that is to say that we proved very clearly and very robustly that starting with immunotherapy is better in terms of survival. Patients live longer if they get upfront immunotherapy, regardless of their BRAF mutation status. So that's why I said that most of the time I start with immunotherapy no matter what. Now, unfortunately, at least once a month, we get called in to see somebody in the hospital who's very, very sick. And I know I don't have time to, literally don't have time, that they won't be alive for me to give them immunotherapy. We have to give them something to work very quickly. This is what we call debulking. And so in those rare cases, I would say under 5% of patients where they're very symptomatic, they have a very high disease burden, they're just not going to make it long enough to get the benefit of immunotherapy. There we start with targeted therapy, which is the BRAF MEK pills I'm referring to. For a BRAF mutation, we start for several weeks. And once they have cooled off, essentially, we stop and then we give them immunotherapy. That's an approach that's also backed by two very good clinical trials. But by and large, we do start with immunotherapy.
Now, how about your thoughts about that in an adjuvant setting? Is there the same type of, robust scientific evidence in giving immunotherapy versus BRAF inhibitors in an adjuvant profile?
No,
Yeah.
absolutely, there is not. So, in the metastatic setting, stage 4 melanoma, we know undoubtedly immunotherapy first is better. Nobody would argue with that statement. In the adjuvant setting, meaning post-op, and we're doing a cleanup job medically, we're trying to kill any cells that might be left circulating. This is what we call adjuvant therapy. It's really to decrease your risk of recurrence. We can use targeted therapy if a patient has a BRAF mutation. And to be specific, it has to be for anything, by the way, when we're talking about BRAF, it has to be BRAF V600E or BRAF V600K, which is less common. There are others which we are not discussing today, but these are the most common. In the adjuvant setting, we absolutely do not know which is better. There is no head-to-head comparison. There probably never will be a head-to-head comparison. These trials are very difficult to do. And so we make those decisions every day on a patient-by-patient basis. So if I see a patient who's BRAF wild type, meaning they don't have the mutation, and they have stage 3 melanoma, and they've had surgery, I talk to them about immunotherapy. That's the only option. If they have a BRAF V600E or K mutation, I talk to them about the pros and cons of immunotherapy versus targeted therapy, and we talk about what makes the most sense for them.
Yeah. And I think that's such a big, important distinction to make because the landscape is so very different in metastatic versus adjuvant. And so, I appreciate, you being candid about that there's no one better thing because there are, there's we try to, focus on what is best for the patient. Like, here are all the pros and cons. What do you think fits best into your lifestyle? Because what's great for one person is absolutely not great for someone else. So I think that's such an important distinction for patients. I want to kind of switch gears a little tiny bit because now when we talk about kind of prognosis and recurrence predictions, there are some new things that we're using that are not necessarily of therapeutic benefit. to sort of monitor patients. So I want to kind of talk a little bit about that now. And so what I'm referring to, is obviously like minimal disease recurrence and all of that. So do you want to start by giving your opinion about how we use genetics for recurrence predictions?
Yeah, I mean, I'm all for anything that can give me an additional data point, but there
Yeah,
are several caveats. So what Melissa is referring to is very new assays or tests that we utilize in the clinic very, very often to detect whether or not there's any shedding of the tumor cell DNA into the bloodstream. That's what you're referring to, right? Okay, just make sure
absolutely.
we're on the same page.
Yeah, we're
Okay.
on the same page.
Okay. So we have different tests and there are different manufacturers for this and that's a whole other conversation. But we draw blood in the lab and it allows us, excuse me, in the clinic and it goes to the lab and we can see there's a number we can see of the copies of ctDNA or circulating tumor DNA or cell-free DNA from the tumor in your bloodstream. There should be none, obviously. Then
Mhm.
if there's any, I get twitchy because that tells me that there is residual disease, microscopic excuse me, molecular residual disease, MRD. And so, of course, the context is very, very important. If this is somebody with metastatic disease, of course their ctDNA is positive. But if it's somebody who's had definitive therapy, meaning they've had surgery, they've had a year of adjuvant therapy, they should be without any evidence of disease anywhere. And let's say in this patient, the scans are clear, but their ctDNA is positive. Well, that's not good. It's probably only a matter of time until something crops up on the scan. So the context is really very, very important. And I say to every patient, this on its own doesn't mean anything. This is an additional data point, and I have to put this with your clinical status, and I have to put this with where you are in your treatments, and I have to put this with where your scans are. And I have to look at it over time. So I just want to stress it's an additional data point. And we have all been burned,
Mhm.
whereby the ctDNA is totally negative and something crops up on the scan, and
Yeah.
vice versa.
Yeah, I think we've, in our specific clinic, have seen some limitations, especially with patients with brain mets, having, the ctDNA be negative in those patients, perhaps, and then we do their scans and find disease in the brain. We've had that happen to us a handful of times over the last year. And so I agree. I think that in terms of using genetic markers as a prognostic recurrence, risk profile, I think they're great as an adjunct. It's great to have it alongside scans. Do you think that there will ever be a time that we only use that? Because I feel like that doesn't seem, unless we kind of hone in the process a little bit more. I just can't see how that potentially would be the only monitoring that we do.
Well, as a scientist, I hesitate to say never about it.
Never. Yeah, true.
I do think in time that's where we will go. I really do. I don't know if it'll be in our lifetime,
Yeah,
but I don't doubt that in time getting PET scans and CT scans is going to seem completely archaic.
sure.
That we will get a very, very good picture with a drop of blood. I don't doubt that at all. But we're not there now. And then one caveat, of course, the brain, we've all been burned there. That makes
Mhm.
sense, right? You're presumably shedding into your CSF, not into your blood.
Right.
Another place that we've been burned is in low burden of disease. If a
Hmm.
patient has uh, stage 2 disease, stage 3 disease, they're shedding so little that the assay is not sensitive enough to pick it up. That happens. I've certainly been burned there a lot. And then the last thing I want to say is I can't overstress the importance of the clinical context. If somebody's ctDNA spikes, well, maybe it's because you just had surgery.
Sure.
Maybe it's because you just had immunotherapy or you're on targeted therapy and all the cancer cells are dying, so they're leaking ctDNA anywhere, in which case I'm delighted. So
Right.
don't try and read too much into it. I mean, of course, by all means, advocate for yourself, but talk to your doctor, talk to your healthcare provider about what they think the test means, because that varies greatly in
Yeah.
each case.
Right. It's not the end all be all. Like it's just because this
No.
happened to go up or down doesn't necessarily mean one thing. So,
Sometimes it spikes and patients are very, very, very worried. And we say, just wait, and it comes back down. I mean, it's a You are a living being. Things are going to fluctuate. That is normal. Nothing is going to be
Right.
stagnant. It's the trend over time.
And one of the things that I know we've been using, at least in our practice, is using the ctDNA sort of as a marker of when we can stop therapy in some patients. They maybe have negative scans. Um, I know we've felt sort of at this like 1 year mark for metastatic disease, like do we stop? Do we keep going? And we've looked at the ctDNA a lot in those patients to say like, okay, you're having some side effects, your scans have been negative. Do we feel like at that marker point, can we stop at a year if your ctDNA is negative? And we've talked a lot about that with patients and kind of explained how um, it's both good and bad to make that decision. I don't know if you wanted to remark on that at all.
It's very much a patient by patient decision. If somebody's tolerating therapy well, would I stop at 1 year in the metastatic setting? No, there are certainly trials looking at that question, right? PET stop, et cetera, et cetera. Uh, but all of that to say, I don't think the question has been definitively answered. Now, if I have a patient where I want to stop because they're having toxicity, and I worry I'm tipping into the do more harm than good, which is
Mhm.
obviously the last thing you want to do for every patient. But when I feel I'm approaching that line and I'm looking for an excuse to stop, if you will, or not an excuse, but a rationale for stopping, I will talk to the patient and I'll say, listen, I think I'm coming to the point where I'm going to do you more harm than good, and your ctDNA is negative. Now, it might come back up. I don't know. But as of now, everything I have right now, let's stop. So yes, I've done that too. But
Yeah.
I certainly would not do it if I didn't need to stop for other reasons.
Sure. I don't want to run out of time, so I want to try to address a couple of these questions. One of the attendees asked, do the primary tumor and any sentinel tumors, and this would also go for metastatic tumors, show the same type of mutation?
That is such a good question. So, as a general principle of oncology, oftentimes the answer is no. So, in lung and in breast, every time we see progression, I mean, I don't treat these diseases in clinic, but obviously I'm an oncologist. Every time we see progression, let's say in the hospital or in other clinics, those patients' tumors are biopsied because they can change. Melanoma tends to have very high fidelity between the primary tumor and different stations of metastasis. So if somebody's BRAF wild type or BRAF negative, a diagnosis, we are not typically rechecking at subsequent stations of metastasis, which is very different than breast and lung.
Okay. So, that's a great answer. The other thing that I wanted to just quickly from the website, because I think this comes up a lot in patient questions, is um, and it's not really what she's asking. But this person had the BRAF mutation, but was given immunotherapy, and she had a great response to treatment. And I think the question comes up a lot. If I'm BRAF positive, why does that mean that I will not respond to immunotherapy, and vice versa? If I'm BRAF negative, does that make a difference with my response to immunotherapy? We get that question quite a bit in clinic, and on the Ask an Expert line.
No, it doesn't. I want you to completely uncouple in your mind response to immunotherapy from BRAF mutation status. We start with immunotherapy regardless of BRAF mutation status because we know that is the best survival outcome. And as oncologists, survival, of course, is the most important endpoint that we look at. It used to be that if you had a BRAF mutation, it was not good because BRAF mutant disease is very, very aggressive. Now, I don't look at it as good or as bad. It just is. And in fact, maybe the silver lining is I have a whole other tool in my arsenal with which to treat you. But I do leave that in my back pocket. I don't lead with it unless I have to. I lead with immunotherapy. Does that address the question,
Yeah,
Melissa?
I think so. And that's it's a question that we get all the time. Like, well, does this mean that I can't respond?
No,
Oh,
not at all.
yeah,
Not at
exactly.
all. You are not more or less likely to get benefit from immunotherapy if you are or are not BRAF mutation positive. Totally separate. That's what I meant by uncouple. What I can tell you is if you're BRAF negative, There's no way you're going to benefit from
Yeah.
BRAF targeted therapy. In fact, we stand to make things a lot worse for you, which is why we have to know the BRAF mutation.
Exactly. One last question, because I think this is also pretty important, and it kind of lends to kind of mutations within the tumor. A patient had, or a viewer had asked, why does a tumor sometimes begin to grow after a good response to immunotherapy?
Well, this is what me and my lab and every other melanoma person in the world is trying to
Mhm.
answer. And it's the fundamental question. What you're asking is, what are the mechanisms of resistance to immunotherapy? And that is a
Huge, huge
huge
question.
top. I'm trying to think of where to even begin to approach it, but the very short answer is you start responding and then you stop responding because one or more of the melanoma tumors develop resistance to the immunotherapy. And one of the things my lab is very interested in is what does the metabolism of the tumor cell look like at that point? What implications does it have for the environment of the whole tumor around it? But there are many other examples. Tumors essentially hijack the immune system. And in so doing, they manage to evade it and to hide from it. But if you think about it as you started here with hundreds of clones, most of the clones are responding, so the scan looks good. But then one or more clones or cell types in the tumor types, or tumor cell types rather, mutate and change. And
Somehow.
they manage to escape, they manage to run away. And what cancer does, which makes it so awful at every juncture, is it puts blinders on your immune system, just like this. And so your immune system can't see what the problem is.
Hmm.
And so any cancer fundamentally is a failure of the immune system. And this is why immunotherapy has been such a blockbuster, because thank God we figured out how to harness the immune system to do what it was supposed to be doing in the first place, which is not let the cancer happen.
Exactly. Now, are you looking at things like TERT mutations and things like that in clinic as well?
It's reported as part of our own panel. It's reported in a lot of different panels. And TERT is something so often seen with BRAF, as you know. They very frequently go hand in hand. So it's information that we have on a lot of patients.
Just we don't have anything to target those types of people
Exactly,
yet.
exactly.
So where do you think the future of genetic testing is going? And then we'll end with that.
Well, in a dream scenario, several different places. One is to have a better prognostic biomarker, i.e., how can I decide in the clinic who's going to do well and who isn't, whose disease is going to recur and who isn't. That test would be very, very helpful because now we monitor everybody, but we probably don't need to.
Hmm.
Um, if you think about patients with stage three, most opt to get treatment. If you look at patients with stage two, many opt to get treatment. There is no doubt that there are patients getting treated who don't need to get treated. Their disease just wasn't going to come back anyway. We just don't know who's who.
Hmm.
And there are patients who, no matter what you do, they get the whole year of treatment, it's going to come back.
Right.
And this is what makes these conversations so difficult in the clinic. And that's one. Second of all, some kind of a biomarker, perhaps genetically driven, of toxicity. Who's going to
Hmm.
have side effects? And how do you couple those together? How do I figure out who's not going to recur and doesn't need anything? Who's going to recur, but the treatment's not going to work? And they're going to get toxicity to add insult to injury, et cetera, et cetera. So
Yeah.
the more biomarkers we have to determine how the disease is going to behave and whether it's going to respond to treatment and whether the patient is going to get toxicity. And these are all huge areas of interest and of research, which I have the privilege of being involved in, like many in my field. I think that's the next mega frontier.
Gosh, that would be so nice to be able to tell someone this treatment's going to work for you and it's not going to make you sick. I mean, could you
And what
imagine?
you're talking about is predictive biomarkers of efficacy and toxicity. In fact, I was on a call just before this one because I have the privilege of leading the immunotherapy subcommittee of ECOG, and we said that this is the cardinal theme. This is what we're trying to answer. This is where the field is going. And that's not a melanoma disease group, that's a tumor agnostic disease group, you
Mhm.
know?
That would be amazing. Um, Dr. Najjar, I really so much appreciate you coming on and doing your magical thing of explaining complicated things at a very understandable level. And even though you don't, you start out by saying, I'm not sure. Let me know if I start speaking crazy. Like you are so good at this. So I just wanted to tell you thank you so much for, I know all of our listeners appreciate you and your information and I just wanted to say thank you again.
I appreciate it so much. I saw a question pop up about something about scans. I just want to make sure we address people's questions. Is there anything that
Sure.
I can answer?
Let me see. CT, da, 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 da. So I was trying to not do specific things so that way we didn't kind of cross over HIPAA. So I was trying to screen them for things that I thought we wouldn't take us too off track.
Okay. Is it
But
okay if I answer one question?
yeah, please go ahead.
Because this person really hit the nail on the head. So somebody asked, thoughts on not giving scan information and ctDNA
Oh
information
yeah.
before patient meeting. Listen, sir, if you can figure out how to do it, please tell me. This is a federal mandate made
Yeah,
by people who know nothing about medicine, who think they know better than we do. Patients will see before I do that they have a brain tumor. It is terrible. And it's
terrible.
completely out of my hands, completely out of any of our hands. Please know, we did not make these rules. This is law by which institutions have to abide. I tell every patient, if you can quell the urge to look before you see me, please do so that we can talk together.
Oh, the other thing that is also a law and also drives me absolutely bonkers is when patients get a letter in the mail that says there's an abnormality on your recent scan, but it doesn't tell them what it is. And so then they are sitting at home completely terrified when it could be something as stupid as, there's a clip or you might have pneumonia, which are serious things, but not cancer related. So I share your frustration and all of that
And
information.
and even in a clinic as well oiled as ours are, we follow hundreds of patients. We
Hmm.
we have a very clear way of doing things. Like I have a whole schedule of my team. We look at scans here, we look at labs here, we follow up
Yep.
here. But there's an excellent chance you've seen it before I've seen it. And
Yep.
that's just terrible. Yeah, I couldn't
Yeah.
agree more.
Well, good. I'm glad you got to address that one very
Got to
important
vent.
topic. That's right, exactly. I'm glad when you hop the fence. It makes me happy. All right, so we are going to end there. I wanted to say thank you again and thank you to all of the viewers, and we'll see you next time.